All right. My name is Jody Jaggers, and I'm with the Kentucky Pharmacists Association, and I'm keenly aware that I'm pretty much all that's left of you on lunch, so I'm going to do my best to get through this. You've heard a lot about naloxone today. It probably has been mentioned in almost every presentation, so I'm just going to talk to you a little bit about naloxone specifically today from a chemical perspective, what the drug is. Of these objectives, the main one that I really want, especially the future prescribers in the room, and even the current prescribers to kind of have an understanding of, is to understand, one, how naloxone is supplied, and also how do you go about identifying patients that would be good candidates for naloxone and writing it, and then how do you write a prescription for it. I know your pharmacology and almost all of your classes in your coursework is small compared to everything else that you do. So hopefully this will at least give you a little bit of an understanding about this. So first and foremost, what is naloxone? Okay, it's a generic name of a chemical that is a synthetic chemical. It does not exist in nature. You can see the actual chemical name there is N-allyl noroxymorphone, and the oxymorphone part is important. Dr. Brenzel did a great job of hitting what antagonists do, and this is a competitive non-selective antagonist. And non-selective just means that it will, any opioid receptor in your brain, it will jump on. Now, it is non-selective, but it does have preferences. So you've got three basic opioid receptors in your brain: the mu, the kappa, and the delta. And naloxone is really, it likes the mu receptors the most. So that's the one it's going to go to first, but it's going to hit all of them, delta and kappa as well. So that's just something to keep in mind. As with a lot of drugs, the mechanism of action isn't really fully understood. They know it works. They can't exactly pinpoint how it works, but they know this is the general idea. It's very lipophilic. That just means it passes through fat easily. And so because of that, it gets into the brain really easily. And that makes it very uniquely designed as a drug to treat overdose. And so this is kind of a visual there. You know, when you have an opioid molecule come into your brain and sits on the receptors there, when naloxone is introduced in the system, naloxone fights it. It kicks it out. It wants to be there. It's important to note, though, that naloxone does have a half-life. It is not going to stay on there forever. So when you administer naloxone to somebody, there is a window of time before that naloxone wears off. So depending on what's in a person's system, they could still overdose. They could still have the naloxone wear off. And even if they don't take another hit or another drug, they could still overdose because of what's circulating. So a little bit of the history of it. This, like many drugs, was discovered serendipitously. They were not looking for a drug to reverse overdoses. They were looking for a drug to help with opioid-induced constipation. As prescribers, it's really good for you to know that when patients are on chronic opioids, one of the things that they experience with that is chronic constipation. And so that becomes a real problem for a lot of patients that are on chronic pain management with opioids. And even now, there are drugs, they're still looking into that. You know, there are drugs on the market specifically for chronic opioid-induced constipation. So that's what they were looking for when they came up with this drug. And they realized very quickly that it completely blocked or antagonized the receptors and prevented the opioid from working in the system. It wasn't approved for 10 more years by the FDA as an overdose reversal drug. It took another 35 years for them to realize, hey, maybe we should actually utilize this in communities, because up until then, from 71 to 96, it was basically used in hospital settings for reversing anesthesia. It was used on crash carts. It was used in ambulances, places like that. But the general public really didn't have ready access to it. There wasn't a push to increase the access. And so in 1996, you had 15 different states and DC that piloted take-home programs for laypersons. And then the CDC has reported, and this is ongoing data they're collecting as well, but in 2014 they reported that at least what they could find, 26,000 people had been revived from opioid overdoses by lay individual, by non-medical personnel. And so most recently in the history of naloxone, on April 5th of this year, U.S. Surgeon General Jerome Adams basically issued the first Surgeon General advisory in a number of years saying that, in a nutshell, everyone should carry naloxone. He likens it to learning CPR and just being a good citizen, to understand that you can be a hero. No matter who you are, you can learn how to save a life, and you can carry naloxone, and you can be that person that can make a difference. And so that's been kind of the most recent history on that. A little bit about the side effects and safety. Again, naloxone is very unique. It only does one thing in the body, and that is that it blocks the opioid receptors. Now, there are some minor side effects that it has, but that is the most significant one. And most of the side effects are really difficult to know whether is it the drug that's causing it, the naloxone, or is it reversing an overdose. Because as you can see, nausea, vomiting, agitation, dizziness, these are all things that can come with an overdose and with being reversed. Headache, tachycardia, hypotension, or hypertension. So again, the side effect profile is pretty benign. If all of us today had Narcan and squirted up our nose, most of us wouldn't feel much of anything other than just maybe the discomfort of squirting something up your nose. So it is very safe. With that, the only real contraindication or people that aren't supposed to take it is if you have a sensitivity to naloxone. And I've not seen any reports of that. It's more of a theoretical thing. You could be allergic to anything. You could be allergic to a component of however it's formulated. It's not really likely. And so unless you know you have an allergy to naloxone, it's not a problem to take it. It's safe to use as a result in pediatrics and adults and animals. And I'll put animals on there just because I think it's helpful to know, both as the public and as prescribers, that a lot of times in law enforcement in particular, police with their canine units will carry naloxone with them, because if a dog gets into fentanyl or some powder like that, they can overdose just as easily as a human can, and this can be used to reverse an overdose in an animal as well. And I've even had patients tell me that their dog got into their trash can and pulled out a fentanyl patch that grandma was on and chewed it up, and the dog overdosed. So it is a good idea to have it around if there's any opioids in the house. The one thing of note, it's generally considered safe in pregnancy. It is a pregnancy category C, and that really just means that there's not been any studies done. The biggest risk is not so much that the drug would cause problems, but it does cross the placenta, and as a result, if a mother is struggling with substance abuse and she has got a high tolerance, that baby is also, the fetus is going to have a high tolerance as well. And if you introduce naloxone, not only is the mom going to feel withdrawal side effects, the fetus is going to feel withdrawal side effects, and so that can stress the system and can cause problems there. So that's why they don't recommend it in pregnant women unless it's to save them, unless they've overdosed and the alternative is for them to die. So how is it supplied? Naloxone comes in a lot of different commercial formulations. Up until fairly recently, it was only available in prefilled syringes and vials, but we'll kind of start with the most common ones that you're going to recognize, and then we'll go down to the ones that are maybe a little bit less common now. But Narcan is the one that probably all of you are going to recognize the name of, and Narcan's claim to fame is that it is the only FDA-approved nasal delivery system for naloxone. There are other ways to put it nasally, and we'll see one of those in a minute, but those were not ever formally approved. Narcan is. It's super easy to use. I teach people to use this regularly, and I would feel comfortable teaching even a 5-year-old how to use it if they were in a situation where they had a family member or somebody that needed to. It's that simple to use. But you really just peel the pouch open, you hold it like you do a nasal spray, any kind of traditional nose spray. You spray it. One of the big things here, and this is a take-home for your prescribers as you counsel your patients, you don't prime naloxone. With every other nasal spray that you're going to ever dispense, pharmacists are going to counsel, and you'll maybe even counsel them that you prime it to get a few mists. If you do that with naloxone with Narcan, that dose is gone. You've wasted it. So you don't push the plunger in until it's in their nose. I've got pricing on here just so you understand a little bit. If you walked into a pharmacy and got Narcan, it's going to cost you about $150 with no insurance. Insurance pays anywhere from complete amount all the way up to whatever your copays may be. You're probably never going to pay more than that, but that gives you kind of an idea. Public health pricing for us is about $75 for 2 doses. They come in a 2-dose box. If you come by the mobile pharmacy and check us out, I'll have some examples of Narcan and FZO as well, so you can see what it looks like. FZO is the other product that you may have heard a little bit about. It's one of the other big brand names. It's a great product. It's an auto injector. So you hear talk about EpiPens. And the nice thing about FZO is it talks to you. And it's kind of foolproof because of that. Once you open the package, a voice starts talking to you and telling you what your next step is and how to do it. The problem with that is it is really expensive. It costs a pharmacy around $2,500 just to shelve it. And so it's even more than that for retail. Now, the company that makes it does have some incentive programs and some discount coupons that knock the price way down, but it's just cumbersome to keep on a shelf because it is so expensive. But it is an option that's out there. And there's no needles that you see or that you fool with. You just put it on the leg, hold it firmly, and when you do that, that activates the device. So it makes it a little bit easier. That's one of the reasons why, just to go back, Narcan we use in most of our educational components because it's not intimidating. A lot of people are scared of needles. There's no needles. There's nothing to do with this. And even FZO, even there are needles, but you don't see the needle as the person using it. So it's a little bit less intimidating there as well. The prefilled syringe with Atomizer. So this is the other nasal form, and it can be nasal or intramuscular. So the syringe itself comes, and it comes with the naloxone as a liquid in it, and it's got a little lure lock, which is just a mechanism to screw a needle on the end, and you can use it to give it intramuscularly. However, more commonly what we're seeing is a device was developed, and it's called an atomizer, and you can see there it looks like a little cone. You screw that on the end of the prefilled syringe, and it works in very similarly to Narcan. When you press the plunger in, instead of it coming out as a jet or as a stream, it's going to come out as a mist. Biggest difference here, same drug, same chemical entity, it's just this was never approved by the FDA to be given this way, but the FDA is not saying anything about it. They've approved the device, the atomizer, but not the actual delivery system. Just a little bit of a caveat. Big difference here, though, is you only give half each time. So the first nostril, you're going to give half the syringe. The other nostril, you give the other half of the syringe. And that's a complete dose of naloxone when you administer it. A little bit more to fool with. You actually have to prep it and put it together. So that's one of the reasons we don't use this when we're doing the education for the state programs that we're doing. Again, it's just a little more complex, but it's still fairly simple. And then lastly, vials and ampoules. These are primarily going to be in hospital setting and maybe in the ambulance settings. Of note for anybody that maybe isn't familiar, an ampoule, if you've ever used one, it's just a little glass vial and you break it open. You do have to use filter syringes with those, so keep that in mind if you ever wrote that, or if you ever wanted to use prescription for an ampoule naloxone, is you also need filter syringes, and that's because when you break that glass vial, you could potentially introduce glass shards into the liquid, and you want to have a syringe that can filter all those out. So not super practical for public use. That's why you're going to see that mostly in a hospital. So this is something I really want you to kind of pay attention to and listen to, is who do I consider, if I'm prescribing, who do I consider giving naloxone to? And it's important to note that it's not just for people that are struggling with substance use disorder, okay? Your first question is going to be, does my patient have a history of substance abuse disorder? Are they currently struggling, or do they have a past history? And that's why it's really important to have a complete medical history of all of your patients. It's really important, if you can, to have a relationship with these patients so that it's not just a clinician. You know, there's a little bit of trust there, so the more you can build trust, you know, they may not tell you right up front that they have a history of that, or you may have to pull that out of them. But it's important to know that, because if they do, and you're prescribing either an opiate or whatever other kind of treatment you need, naloxone is probably something you want to prescribe with that. Second question, if they're on opioids, and this is whether you wrote the prescription for the opioids or another prescriber, if they're on opioids, what's their total dose? Are they on a high dose? And you know, if they're on like a morphine equivalent dose of 90 to 120 or greater, they really need to have naloxone on hand. Casper is a great resource for you as you get out into practice. They've changed Casper now, that you can get a whole other presentation on how to read and interpret and use Casper in your practice. But the Casper reports, which is Kentucky's all-schedule prescription electronic reporting, that's going to give you a resource that shows you what their morphine equivalent dose is, and it's a number that's on every Casper report now, so it makes it real easy. The next thing you want to ask, and this was mentioned earlier, is my patient on a benzo? Are they on Valium? Are they on Xanax, alprazolam, lorazepam? When you combine these drugs, just like when you combine alcohol with opioids, now you've got a greater risk of overdose. And so these could be legitimate patients on legitimate prescriptions, and just because of the nature of what they're taking together, they're at a higher risk. Another question you want to ask is, does my patient have any kind of a history of mental illness? Any kind of mental health condition, not just mental illness, but health condition. So are they an Alzheimer's patient? You know, if your grandma or your aunt or your uncle has dementia or mental illness, or any mental cognitive decline, and they're on an opioid and they take their morning dose, and then they forget they took their morning dose, and they take their afternoon dose 10 minutes later, they can stop breathing just like somebody that was on something illicitly or misusing it. So something to keep in mind, just as you're screening your patients, to think through if they're on these medications, they probably need to have naloxone at home and have somebody trained on how to use it. Do they have other medical conditions? And so this in particular would be respiratory disease or other comorbidities. I mean, we know that from an opioid overdose, you die because you stop breathing. If you already have COPD, if you already have asthma, you're just at that much higher of a risk of stopping breathing. And so these are things you want to know as a clinician, as a prescriber. Hey, my patient has got COPD and they're on an opioid. We need to make sure they have naloxone, and that somebody in the household is trained on how to use it for them. Sleep apnea, I heard you mention earlier, is one of those things that is kind of a silent killer that we often don't think about, but that is a respiratory problem that may not manifest itself with COPD or asthma, but it's still a problem. Somebody goes to sleep with sleep apnea, they take their evening dose of an opiate, and maybe they don't wake up because they already have breathing issues because of that. And then the last thing to consider, and this is where really anybody can be a candidate for naloxone, is are they in a position to help someone? And that's where you really want to think about in your practice setting, okay, are they a caregiver? Do they have a loved one that they're taking care of that has one of these other conditions? Are they a social worker? Are they somebody that works with at-risk, youth? What is their, do they volunteer in the soup kitchen regularly? These are things that if you have dialogues with patients, you can really start to see areas where they can make a difference and where you can prescribe something like naloxone and help them, again, to be a hero. So how can people get naloxone? Anybody that's in Kentucky that's a prescriber that has prescribing authority, so doctors, DOs, nurse practitioners, DMDs, PAs, if you can write a prescription in Kentucky, you can write a prescription for naloxone. Earlier, if you were listening to the name, oxymorphone at the end, that may make you think that it's a controlled substance. It's not. Naloxone is not a controlled substance. It is a prescription product, but it is not a controlled substance. Another way people can get naloxone is pharmacists can dispense it as long as they're prescribing under a protocol from a physician. And the reality is every chain pharmacy in the state now is doing that, and quite a few independents as well. So somebody can just walk in off the street and say, hey, I'm interested in naloxone, and pharmacists are going to go through a checklist of some things they have to educate them on, and then they'll just bill it to their insurance, and they can walk out without ever having to go see a doctor. And then there's also community education events that are regularly happening around the state. I'll talk a little bit about some of those that we're doing with the mobile pharmacy, but you can just have, tell people to just keep their eyes open for, any number. It seems like every weekend, especially back during the summer, I was getting requests for the mobile pharmacy, hey, can you all come to our community event to do naloxone training? So I feel like one of the things that's probably tough for prescribers in particular, and I don't know how much you get in your respective schools, is how to write prescriptions. And this is an area of great conflict with pharmacists and doctors. For any of you that are in practice, know anytime you get those exasperated calls from your pharmacist on either not being able to read your handwriting or not being able to interpret what you've written or with questions on it. And so I want to talk to you just a minute about how to actually write a prescription for naloxone, just so you understand what to do. Again, it's not a controlled substance. Anybody with prescribing authority in Kentucky can write it. There's no special prescription blank requirements. So, with controlled substances, you have to have a security blank, and there's a lot of details there. You could write this prescription on a napkin, and it's fine. It can be prescribed via telephone or any electronic prescription, including fax. And so something that's important to note is you always want to indicate on your prescription to call 911. And that was talked about through some of the previous presentations, but this is not a fix-all. This is a Band-Aid. Naloxone just buys time for people. It doesn't fix the underlying condition. It's the same thing if somebody has a heart attack and you bring them back with paddles. That doesn't fix their heart disease. That just gives them a second chance. And that's what naloxone really does. It gives somebody a second chance. But for that to be effective, you really need to make sure they're getting treatment beyond what you as a responder maybe you're doing. So as a prescriber, the first thing you need to do is write on there, call 911. Something to keep in mind is insurance may not cover all formulations or certain formulations. For instance, the Evzio, because of the nature of its cost, may not be preferred. You have no way of knowing that, and I wouldn't worry about that as a prescriber. That's not your responsibility to know that. That's where pharmacists will help you. And also know that your computer software probably already has the directions linked. I'm not going to read all these to you, but if you are watching this or if you have access to this after the fact, this gives you some idea on what a sample prescription might look like if you wanted to be very specific about each product. Again, notice all of them have not call 911. This would be the prefilled syringe with atomizers or the syringe with vial. And the next thing, though, is if you wanted to write a prescription that's as short and sweet and to the point as you can, that covers all the stuff that you would need and that's going to minimize a call from a pharmacist, this is what I would suggest writing. Just write naloxone per formulary. That way, the pharmacist now knows that you're okay with whatever is covered on their insurance. Call 911. Uses directive overdose, and again, their software is typically going to plug in the complete instructions, or the pharmacist is as well, and then whatever the quantity is, or quantity 1, and then your name, and always be sure that you sign on the substitution allowed so that there's no confusion. I'm not going to tell you that every pharmacist is going to fill this and not call you and have questions about it, but a lot of pharmacists, and probably the majority of pharmacists, if they saw a prescription like this, will feel very comfortable filling whatever is covered on the patient's insurance or whatever they're comfortable with. So what are the current initiatives right now that we have to increase access to naloxone? We've got parked out here today, and I hope you all come by during lunch if you have some time. It's our mobile pharmacy. Kentucky's really unique. We are one of only 2 states that has a mobile pharmacy that's state-owned. It's technically an emergency preparedness tool, which just means that we could be activated if things got really bad and there were pharmacy services needed in a community after a natural disaster, or if we were sheltering people that were maybe displaced from a hurricane on the coast, and some of our partner states sent people to us to help out. But since 2016 in November, so we're coming up on 2 years, we've had this partnership where we have been actually utilizing pharmacist ability to prescribe naloxone via physician protocol, and that was granted back in 2015 from Senate Bill 192. You all may have heard of that in the news. They called it the heroin bill, was what a lot of the news agencies were reporting on. But that allowed us, among other things, that allowed pharmacists to, with protocol, give naloxone out in the pharmacy. When we do these events, they're typically just in conjunction with the local health department. They call and request our presence. We've been in 48 different events in 44 different counties in Kentucky. Most of it's been in the eastern part of the state, but we have been in western Kentucky a couple times. And we've almost given out 3,000 different, 3,000 two-dose packs of Narcan. So we've been busy since 2016, and we've had a really good turnout of pharmacists and student pharmacist volunteers. That's a picture of it. Again, you can see it firsthand for yourself if you want to step out. We're parked around the corner over here, so it's a very short walk, and it's a beautiful day shaping up outside. One of the other initiatives, and Dr. Brinzel mentioned this, is the CORE initiative, and KPHA has partnered with CHFS with the CORE initiative, and what we're doing is we're using local pharmacies to dispense naloxone primarily to residential treatment facilities, so they go in and educate the residents, people that are in recovery that are seeking to clean up, give them the education, and then send them home. So when the patient leaves, they go home with Narcan and with the knowledge on how to do it, because that is probably the single highest risk population for overdose, is people that are trying to get their life back together. And if they mess up that one time after they've been clean, that can be all it takes for them to die. And so sending them home with the knowledge on how to recognize overdose and how to prevent it, and then also how to respond to it. Maybe it's not their life they save, maybe it's a friend's life that relapses, but that's the goal of that. Right now we've got 21 pharmacies in 19 different counties participating, and we've dispensed a little over 1,200 two-dose packs of naloxone. This is just a map that shows kind of where we've been, either with the mobile pharmacy in yellow, or in green, or blue is counties where we just have a partner pharmacy with the CORE initiative. And that's all I've got. Does anybody have any questions about naloxone or about any of the initiatives at all? All right. Thank you all.